Friends, good evening. Welcome to the skill development course of Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India in collaboration with Medtronic India. This is the second module. In first module, we had a very successful event and which covered minimally invasive mitral valve surgery, and we had two speakers in the field, and both did justice to their task. We had Sardari Nia from Netherlands and Dr. Pavan Atluri from University of Pennsylvania, Philadelphia. Today again we are very much excited, and the area which is going to be covered is minimally invasive aortic valve surgery. Today we have two great leader in the field of minimally invasive cardiac surgery, Professor Kofidis and Dr. Cheng Han Yap. We have also the panelists, which are Dr. Anwar Miller, he is the Vice President of the Society. Then we have Dr. Rajneesh Malhotra, who is the General Secretary of the Society. And we have Dr. Lalit Kapoor from Rabindranath Tagore Narayana Healthcare, Calcutta. Then we have Dr. Bijit Cherian from Moat Hospital, Chennai. And the last but not the least, Dr. Chirag Doshi from Ahmedabad. Let me first of all welcome Professor Theo Kofidis. He doesn't need any introduction. We all are familiar with his association with our association, and also he was the one who addressed, in fact, when we had a first meeting in Delhi. He has been numerous times in our Indian Association of Cardiovascular meetings, where the first time I met him in Lucknow, and that was a very, very memorable occasion where he presented his mitral valve works. Professor Kofidis is associate professor in the Department of Surgery. He's a senior consultant and also head of Department of Cardiac, Thoracic and Vascular Surgery, National University Hospital, Singapore. He also heads the Division of Adult Cardiac Surgery. He promotes and offers a wide range of traditional and less invasive small incision and keyhole access procedures for bypass and heart valve surgeries. He has a wide spectrum of expertise in less invasive and hybrid heart surgery, heart failure surgery, and off-pump coronary artery bypass surgery. He is invited around the world to train doctors and nurses in minimally invasive heart surgery as well as keyhole workshops. Professor Kofidis is a fellow of Royal College of Surgeons of Edinburgh and was also elected member of the prestigious American Association of Thoracic Surgery. Professor Kofidis published more than 120 articles in peer-reviewed journals. I'm not going to come between you and Professor Kofidis. Let me invite Professor Kofidis to talk about minimally invasive aortic root surgery, practical tips and tricks. Over to Professor Kofidis.
Well, thank you very much, Yugal. It's more than just professional relationship that connects us and many more interests in the domain of minimally invasive cardiac surgery, but also a friendship that holds over the years, even in times of COVID, separated by a couple of thousand miles. Now, I must confess and apologize in advance because for the first time, it never happened before. Anyways, my videos are not linking to my presentation, but let me share screen and get down to the base right away. So we don't waste any time. Let me go on full screen mode here. Two are maybe three, the ways we approach the aortic valve, aortic root in a minimally invasive fashion, and that is the mini J stenotomy. That is the first step, basically, through which surgeons navigate in order to get to the more advanced minimal invasive procedures, aortic and aortic root procedures. So we have the mini J sternotomy, which I would advise you to start with. Please, Yugal, allow me to be very practical, talking
Please.
about tips and tricks and caveats, not too much philosophy,
Absolutely.
as well as then move on to the RAT, the so-called RAT, right anterior mini thoracotomy. And of course, we have the third and most advanced stage, which is the endoscopic one, which I don't advise you to do in the very beginning of your experience. That comes with time. Now, you'll be surprised to know that with the mini J sternotomy in the third or fourth intercostal space, mostly the third intercostal space, you can reach the entire root. You can reach the aorta all the way to the brain supplying arteries, just as if you had normal sternotomy. You can cannulate from that aspect. What we see here is the CO2 insufflation cannula. I recommend you put a CO2 cannula inside and insufflate about 3 liters per minute. So you'll be surprised to see how much space it gives you when it's not so good, when you have very, very long-standing aortic insufficiency with elongated aortas. In Marfan patients, you will find that even if you open in the third or fourth intercostal space, the heart is rotated to the left, the aorta is elongated, the heart is pushed down to the left diaphragm, and you may have difficulties doing a proper repair. It gives you indeed a very good access. You can do repairs, you can do replacements. I would recommend start with the replacements and concentrate on the repair. What means a syllabus from A to Z, and I come to the end to talk about how to get to such a syllabus, but there are a few tricks that you do differently. For example, if you're not sure whether you should go on the third or the fourth intercostal space, always go for the lower intercostal space to give you a significant space in the beginning until your skills are really developed to the next level. Now, there is no shame, instead of doing an 8-centimeter incision, do a 10-centimeter incision. Most importantly is you don't do the median sternotomy, because what does it do? It doesn't destabilize the chest cavity. The chest cavity is remaining intact, so the patient can recover very fast, almost as fast as through a RAT, right anterior thoracotomy. So in these cases, I'm going to show you, I'm using the Medtronic Avalus valve, which I find very good. Why? Let's say you start your minimal invasive experience with a sutureless valve in order to make the procedure shorter and compensate for the time you're going to lose due to lack of experience in the beginning. Many people start with a Percival valve or with sutureless valve. A very good valve, if you don't have such kind of valve in your practice, the very good valve to start with is the one-cut release valve, like the Avalus for Medtronic, for example, because when you put it into the annulus, you just cut one stitch and it's released beautifully. New technologies like that enable us to start our minimal invasive aortic valve program. What else technology is very important? Cornot, of course. Okay, so the lazy maker, so to speak. We love Cornot. Since we use Cornot in our procedures, minimal invasive program surgery in our program has taken off. Now, unfortunately, I can't play the video here for some reason, but what you see here is from the head of the patient. You see a traditional aortic cross clamp here, vein cannulation in the right atrial appendage, the aorta is open. You see a bypass on the right coronary artery. You'll be surprised to see how far you can reach all the way to the RPDA or proximal RPDA by just putting a 4-0 pledgeted stitch on the acute margin of the heart, pulling the acute margin of the heart. So you can do combined procedures. A couple of our patients come with a single or double vessel disease, which can be addressed in a surgical or a hybrid fashion like that. You have a beautiful view here. I'm trying to pay it, median not found for some reason. Anyway, so you have a very beautiful and fast view of the aortic valve. You can do whatever you want. So I don't see any restrictions basically by doing a mini J sternotomy. And then, of course, pass the stitches through the valve, parachute it down, as you know. And again, my recommendation is for valves that can be released simply and easily. So various stages of reprocedure, and here we arrived at the cornot. You see the shaft of the cornot here, pass the threads through the cornot, you push down. Why is that important? Many times we have very small annulus, We have a valve that hardly passes through the annulus. You want to avoid tearing the annulus and having to do reconstructive or pericardial patching procedures. So the core knot being thin and straight, it can save you a lot of mishaps like that. If I push with my finger down, sometimes the annulus is so small, particularly in our part of the world in Southeast Asia, and calcified, that you can cause damage. So the core knot has a dual effect, expedites your tying time, as well as saves you mishaps. This I would have shown you the final result, very good, low gradient, and the bypass has a nice Medistim result. Here I've done a David procedure. Again, make sure through a preoperative CT scan where is the heart, how it is rotated, and project it over the rib, so you know that if you open the third, fourth intercostal space, you're going to land nicely over the aortic root. It's a pain in the neck if you have to do that and you realize that the aortic root is very deep down. Then don't attempt complex aortic root procedures. And I've done dissections like this, simple dissections. I don't go into very deep, let's say, frozen elephant trunks from here. Some people could, but I prefer not to do it because a dissection can masquerade any possible situation and put you in front of unwanted surprises. Before we go to the rat, some simple advice. What do you do different? When you put the left atrial vent through the right upper pulmonary vein or right pulmonary vein in the mini stenotomy, put an additional purse string around it or a pledgeted stitch before you remove it at the end of the procedures. As you tie down a single stitch, if it tears, you're going to be in trouble. So these are like small tips and caveats that can happen during a minimal invasive aortic valve surgery. Another one, put your pacemaker as well as your chest tube long before you come off pump. Once you come off pump, the heart is filled, you don't have too much space, it's difficult to do these things. You tear your pacemaker electrodes again, you have to put them back in, can't reach the surface of the right ventricle, and so on and so forth. And of course, it's easier to put the chest tube when the heart is arrested, as you can appreciate on the left side of my slide here. RUT stands for right mini thoracotomy, and I will refer to the rules that were first postulated by a good friend, Mattia Glauber, in Italy. When do you choose the patient to do a RUT procedure? So be conservative in the beginning and start with easy cases. A good RAT procedure is when the aorta is actually on the right side. Half of the aorta is on the right side from the right border of the sternum. Here is not the best case to start with. Here the distance is also relatively long to the chest wall. The distance from the chest wall in an oblique fashion here should not be more than 10 centimeters, the inside of the chest wall. And the aorta should be on the right side of the midline. Here is the optimal situation. So I encourage the young surgeon who is starting his minimal invasive program to choose an aorta as on the left side in this patient, where you appreciate that the aorta is mostly on the right side of the right border of the sternum. Now, I wish I could play these little videos I put together in a stepwise fashion, but I can supply them to you by a WIT transfer to your organizer, whoever wants to have it. So there are different schools in the RAT procedure, right anterior mini thoracotomy. I would call one school the Central European school, German, Swiss, and Slovenians, where they don't divide the mammary artery, the right mammary artery, and they do a very small incision in the costal space, partially cannulation from there, and so it's really very tiny. And then we have the American school, which I learned from. My teacher in that was Joe Lamelas, and it's a bit slightly more conservative, but I consider it very safe. You're going to feel much more comfortable. So open in the second intercostal space. What if you're a bit too high or a bit too low, or you're not sure whether you're gonna drop right over the aortic root? Open right over the rib. Open over the third rib, or the periost of the rib. It's not a shame if your anesthetist is deflating the right lung. You can poke a small hole on the second intercostal space, see you like it or you don't like it, move down to the next intercostal space. Now, how about the mobilization of the rib? Yes, I do mobilize the rib and then I put it back down together. There are a couple of tips and tricks how you connect the rib on the cartilage and the cartilage of the rib on the sternum again. We haven't seen any lung herniations, any additional pain or pseudoarthrosis so far in all the cases we've done. Now, there is a school that will, again, not touch the right IMA. Some other school of surgeons will cut it. I cut it personally, okay? It gives me much more space and I don't have to worry about it. Now, practically, let's think, what is the likelihood that a patient who comes for an isolated aortic valve replacement will require bypass procedure in the future, will have to come back for a bypass procedure? Believe it or not, it's less than 2%. Even if this patient comes back after 5 or 10 years for a bypass procedure, the likelihood you're going to use the right internal mammary artery in the vast majority of surgeons around the world is not so high. Let's face it, it's below 15%. So, and again, you get a beautiful view of the aorta. What is the technique? You see on this slide, again, cannot play the video, but you see on the slide that the multiple retraction stitches. Put in a soft tissue retractor and go by the principle of progressive exposure, not only just 2 or 3 around the soft tissue retractor, but more and more and more. Basically pinch the pericardium, pull it and see what pushes the aorta towards the surgeon, which is on the left side of the photo here. What brings the aorta towards you? And then when you find that sweet spot, put another additional silk stitch there for retraction. I put sometimes 10 stitches and progressively bring the aorta towards myself. I've even prepared a couple of small video clips for you for peripheral cannulation. I cannulate invariably peripherally in the femoral artery when I do these procedures. That allows me to utilize the entire space for myself and my aortic procedure in the chest. Femoral cannulation, again, keep it simple. I don't put a peripheral perfusion catheter when I do a femoral artery cannulation, and I never forget the other groin. So cross-clamping in cardioplegia is usually with a malleable clamp, as you see here, where you put the cover of the sheath, you pull it basically, and the signet clamp becomes malleable, so you put it aside and you have ample space to do the procedure. You apply ostial cardioplegia. So you see you have a very good access here to the aortic valve, about 4 centimeter incision, very good access. And the CO2 comes from the lung side, over the lung, on the right side, basically, of the incision. So whether you put a valve or a biological valve, the process is the same. I prefer a valve as, again, here, the avalus, that you have one cut release mechanism. You wash with here. There are some people, particularly in endoscopic aortic valve surgery, I will put the vent through the ribs on the 4th or 5th, through the 5th intercostal space, and then guide it with a right angle through my incision into the pulmonary vein. But in this case, it's direct cannulation of the right upper pulmonary vein. Again, the coronary is next. Surgery. You the air, if you have insufflated 3 liters of oxygen during the procedure, don't worry about shaking the heart too much. If you want to shake for a few bubbles, shake the whole table by grasping into the incision and shake too much, and we have even Coca-Cola effects. That means we induce cavitation phenomena, and the gas will go and produce errors. Okay, so there are various techniques to rotate the table, bring your vent or your deaering side on the anterior surface by rotating the patient and the table. So they are a head up, head down, and so forth. For example, the anesthetist should ventilate the lungs, as you know. So not much shaking of the heart itself. Insertion of the drains. Why I'm showing you this? You see a thin drain here? So this drain I put invariably in all my minimal invasive procedures for the last, I would say, 3 years, and never had a tamponade again. It's a JP drain. So the JP drain can go through the camera port. It can go through the CO2 insufflation port. Very easy to put it through. And of course, I put in my straight drain into the mediastinum. However, the JP drain, I will really recommend put it in. Very easy, very soft, manipulate it around the acute margin behind the IVC all the way around the heart. Lifesaver. And the gradients here. So about 4 to 5 centimeter incision, and that's the final situs here at the end of the procedure. Now, there is no limit to what kind of patients you can recruit. People ask me what are the indications and contraindications? Well, indications are almost all. I will show you some slides on outcomes in a little while. And contraindications for me would be as I shown in the beginning, an anatomically malpositioned heart that doesn't ask for a RAT, for a safe right anterior thoracotomy, but in those cases you can do a mini J sternotomy. Obesity can be a relative contraindication, even though it's relative. You see on the right side here, this patient was 150 kilogram and underwent successfully RAT. 83, 85-year-old patient here who got his RAT procedure, and then 3 weeks later he was playing golf again. So it is indeed very, very beneficial for mobility of the patient. At pitfall and tip 1, the question to perfuse distally or not to perfuse. I don't perfuse distally, and so far I had 0 complications because of lack of perfusion, let's say, in the or any compartment syndrome and things like that. What about preoperative scans? Yes, indeed, at least do an echo. If you don't have immediate access to CT scan, CT angio, that will show you that, for example, in this patient here, you can predict that you're going to have these problems here, healing problems. Obese patients, metabolic, simply calcified iliac arteries in both aspects in the CT scan. The next tip is there is the artery goes into a spasm, or ladies who have been housemaking and never exercised in their lives, which are sometimes obese but very small femoral arteries, difficult to cannulate. Don't worry, there is always the other groin. Go and connect both groins. My recommendation further is don't stitch and fix the vein on the surface of the body. So I'm not going to go into the details of cannulation because this is not my assigned subject today. There are a few things that you should worry about, particularly in small arteries. Don't twist the dilators. Steer the soup like this, but don't twist and strangulate the endothelium of the vessel. So very, very simple cannulation. This is what we do all the time. Nowadays, we're using Del Nido or modified Del Nido cardioplegia, gives us silence for more than 1.5, 2 hours without any problem at 32 to 34 degrees. Here, we evacuate a bit to mix the Del Nido cardioplegia on the spot. The further advantage is it doesn't dilute too much, contains magnesium, and has an antiarrhythmic effect. I hardly see any VTs as per compared to custodial, for example, and it's low volume. Now, my mantra for the minimal invasive aortic key principle: keep it simple. It changed the origin with safe. Keep it simple, safe. Keep it reproducible. So when you teach, you have to have a syllabus from A to Z, go through in a reproducible way that lowers the threshold, adopt, and of course it has to be teachable. A few words about the outcomes. My former mentor and friend Jürg Grunefelder has published the first bigger series over 100 pages and shows that the minimal invasive aortic valve root replacement has excellent results. Cross-clamp time in his series was a bit longer. However, that was the Swiss school with a very, very small incision. Same was found by Joe Lamelas, a very, very prolific minimal invasive surgeon, more than 700 minimal invasive cases a year, who found that the minimal invasive approach reduces postoperative arrhythmia on top of its other advantages. And this is something that I can tally with from our own series. So in terms of various elective post-op complications, deep wound in failure, minimally invasive seems to do better in the same series by lamellas compared to median stenotomy. In our very initial series, when we first started doing RATs and all this, we had a 3 days hospital stay difference already with the median stenotomy. Now all these numbers have been revised. We're
and discuss. Let me ask all the panelists to please unmute yourself so that we can discuss. Yeah, hi Rajneesh, welcome. So yeah, unmute please yourself. Yeah, hi Dr. Cheng.
Hi.
Good evening. Welcome.
Thank you.
Yeah, welcome. So somehow we lost Dr. Kofidis. So let's discuss this part, and let me initiate a discussion and uh, ask the Vijit. Anyway, he has covered the lot of procedures. Unfortunately, BD were not working. So in your practice, what is the range of the intervention which you do through either upper partial stenotomy or right?
Hello?
Yeah, Professor Kofidis is here. Yeah, welcome.
Sorry.
We lost your anyway. You can carry on, please.
Yeah, I'm finishing in 1 minute.
Perfect. Then we can have a discussion. Yes.
So the problem is that eventually the internet is very loaded here in Singapore. We are in the midst of Chinese New Year celebration.
Oh yeah, lot of messages going on. Yeah, please.
Can you see my screen?
Yes.
Okay. Literally, it was almost the last slide. So you see that what is the penetration of minimal invasive valve surgery in Germany, for example, a country that adopts aggressively minimal invasive aortic valve surgery, 47%. In my practice, is now 95% of all minimal invasive aortic valve procedures, isolated procedures. It's 20% for aortic valve 47% for mitral valve replacements and less than 20% in isolated aortic valve replacements. In our department, we're about 100% for aortic valve replacement alone. So indeed, we have a focus, as Dr. Mishra has mentioned in the beginning, on minimal invasive surgery. And what is the mantra to take home with this? I don't want to miss the opportunity to show to you. Conventional aortic valve surgery is still the golden standard, but retreating. We're moving towards minimal invasive heart surgery. Minimal invasive AVR shows lower morbidity in many aspects. It's increasingly popular, starting with sutureless valves and not tying tools with new technology. And of course, we should learn how to walk first and then fly. Start simple, eventually with the mini J sternotomy, move on to the right anterior thoracotomy and then the endoscopic procedure. And use communication and good training tools. Let me see if I am able to show you this. For example, and you will allow me, this is a premiere basically. I am very honored to be able to show you this. Let me see. A totally innovative surgical education tool, which is just about to be launched, is a book we have written along with top minimal invasive surgeons around the world. Is about to be launched on March 26th. The differentiator of our book is QR codes. Basically, you don't only read the text, but you scan the QR code and you can see how the operation is done. It has very strong differentiators. It's an experience. It's not just a book. Has a new chapter structure. And I hope indeed that we'll be able, together with a publisher, a very important publisher indeed, Taylor and Francis in London and New York, to launch it in India together Yugal, and bring it to the young surgeons who will appreciate a lot reading the text, scanning the QR code, and seeing how the surgery is done with all the tips and caveats, hundreds of illustrations, and so on and so forth. A new educational tool that I will offer myself during my proctorships in the years to come. And with that, I thank you very much. Sorry for the technical glitches. You may have to unmute yourself.
Yeah, sorry. So great. Thank you. Thanks, Professor Kofidis, for excellent your disposition of aortic root and aortic valve minimal access approach. Let me also know the people that Professor Kofidis is also the chairman of the Initiative for Research and Innovation in Surgery. I have seen his excellent lab, which he has, and I wish that whosoever goes to Singapore must visit that great initiative which Dr. Kofidis, with some philanthropy from his patients, he has initiated a great research and training tool in his center. Now, this remark, let I ask the audiovisual to put all the the discussion on the platform. Everybody, please focus, everybody, so that we can have a discussion on this part of the presentation, please. So let me welcome Dr. Cheng, Dr. Rajneesh Malhotra, Dr. Vijaycherian, and start from first. Let me start question to Professor Kofidis. You know, we in this part of the world, you already enumerated that we do have a small root. Now, with this approach, RAT approach, can you, if younger patient comes for aortic valve replacement and you could not able to put appropriate size of valve, can you be able to do a root widening with this approach, RAT approach?
Yeah, yes, you can. But if you choose a case in the beginning of your experience where the aorta is rather on the left, of course, when you are more experienced, you can do any aorta, but you choose the aorta that is on the left and struggle with exposure. And let's face it, minimal invasive is all about exposure. No compromise, no nonsense with exposure. Then you're going to run into trouble. But the answer is yes. If you choose a patient nicely indicated, good access to the aorta, you can do everything. Yeah, it's not a big deal to suture a piece of pericardium in the aortic root and extend it. There are other options as well. If you don't have sutureless valves, you may have freestyle valves. You may have small size Oinix valves. There are different ways to address the small root.
So let me ask Dr. Rajneesh Malhotra, who also has some experience of using sutureless Percival valve through this approach. Rajneesh, what is your experience, and when you like to use the Percival valve in this situation?
So, sir, as Professor was saying, that around 50% of our cases of aortic valve, I do minimal invasive because I'm not able to do all, because I'm working in a private institution where most of the patients are being charged for the minimal invasive, and then they are not able to do that, and then we have to really do it in a conventional way. And of the 50%, patients who are affording, and I would say every patient I would like to use a sutureless, because sutureless, if you have, I would say if you know the technique, so it's much more easier. And if the patient is, say, about 60, 65, 70 years of age, and he opts for the sutureless, so my preference is to use a sutureless valve in a minimal invasive, because it saves you a lot of time. It saves you passing the sutures. It saves you a lot of, the tying the knots, and then cutting and doing everything. The only thing you have to be careful about is that your sutureless valve should be seating properly, and it is the aortotomy you have to make is higher than the regular aortotomy, and it should not be a bicuspid. I do not do in a bicuspid aortic valve. If it is a regular tricuspid aortic valve, I would go for a sutureless, provided the patient is able to afford it, because the cost in a private institution always matters. So out of, I would say, suppose I'm doing 50% of my work as minimal invasive and the elderly patients, so I would all of those elderly, if they afford it, then I will use a sutureless.
So yeah, Rajneesh, so with this, because of your point of view that you would like to use sutureless valve, that to a Percy valve. Now the another point comes with this, and we have to discuss that. Now, what I have seen in the North America, because of the availability of Resilia tissue valve now, the people who were too much for intuitive rapid deployment valve, now they are switching over to the Resilia tissue because of the fact that the proven long term whatever is the 20 to 25 years. The Percy valve, I do have experience of using this valve, but I do have some reservation on the tissue quality and the mitral flows, the dismal outcome. So what Dr. Kofidis' point of view on this subject, please?
Well, my view is not far away from yours, Yugal, I must say. Same. When I first started doing Percival valves back in 2012 here in Singapore, I was very enthusiastic, but then I hit the limit again. So I had two in situ explantations for a traditional valve with the X move, basically because of mal sizing and mal positioning. And of course, the cost can be a factor for a subsidized government institution. So as you say, with valve technologies that are much better than the mitral flows, and let's face it, the Percival is a next generation mitral flow or something like that. So I would prefer traditional valves with a good anti-calcification treatment at this point. Doesn't mean to say that I don't use Percivals. I use them in combined surgeries, ideally indicated patients to save time, or certain very difficult minimal invasive cases as a bailout procedure.
Right. So let me ask Dr. Cheng, what is the practice trend in Australia? If you talk of the minimal access approach and use of sutureless or rapid deployment valve, are now newly emerging better tissues like Religlia, or what Dr. Koftis says, Medtronic's Evolus valve. What is the choice of prosthesis there?
I must say the minimally invasive approach is not very prevalent in Australia. I think it's still less than 10% of operations get done minimally invasively, and of those, most of them get a mini stenotomy. The trend is definitely for more tissue valves and less mechanical valves. Mechanical valves are now sort of 5 to 8% of implants in Australia. I think about half the tissue valves are now rapid deployment valves. And yeah, it's gaining popularity. The cost is not a big obstacle in Australia. The funding through the government hospitals are quite generous. So there's not much barrier there from a cost perspective. I personally don't use many rapid deployment valves. I've had, similar to what you've said, I've had some poor experience early on, perhaps wasn't very well trained early on, and I had a few bad experiences, and I don't put them in routinely, only as a bailout if I get a small calcified root. But that happens very rarely because we screen with CT scans now, so we don't get really surprised by these situations. Yeah, so that's the situation over here.
Right. So Vijit, can I ask you the questions? Dr. Kofidis has very elegantly said that when you want to start minimal access aortic valve surgery, it's better to start upper partial stenotomy. And always, whenever I also take a training course and train the people, my also viewpoint is, and I myself started, say 15 years, 18 years back, when I started minimal access aortic valve, I started with upper partial stenotomy. And particularly the reason was at that time because we didn't have a custodial or we didn't have a Delido. So we used to give basically the blood cardioplasia, and the stenotic patient, they used to have very hypertrophic, the ventricle. So if Rajneesh remember that I remember a case when both were together and patients, we did a surgery, we closed and patient fibrillated. And so Rajneesh converted immediately. Again, we put onto the pump, did not put on the pump. I think we gave a massage, gave the shock, and patient came. And that was classical inadequate myocardial preservation. So now with that we have moved on. So always we suggest that in a situation, I just recently I give an example that I had a patient from Bangladesh, and this problem is very, very common with ladies. I don't know, the old ladies, short stature, there where you aggressively try to put in a bigger biological valve, you try to impinge some of the coronaries, and then you had a problem. So in that particular lady, considering all my previous experience, I did our partial sternotomy. I did a 21 size, the Magna Ease valve, and then we released the clamp, and the patient started, the fibrillating. So, we gave some time. In that situation, what I do, sometimes what happens that there is some air entrapment or, something can. So we again clamp and give a cardioplegia and try to, but again they had a problem. Then we just converted and we put in 2 grafts and the patient came off nicely. So because of the fact that, we are not as experienced as Professor Kofidis or Dr. Cheng, so beginners, whenever I take these kind of courses, I do always ask, start with a partial sternotomy, and if you have a problem, easily you just convert. No, converting from the red to the sternotomy, again you are giving 2 big incisions. So tell me what is your approach? How and what is your differentiating point to go upper partial or right anterior thoracotomy?
So Dr. Yugal, what I do is I do go and sit with the radiologist and try to figure out, which space, like Dr. Kofidis said, we need those criteria for rightward aorta and the distance from the rib to the aorta were very valid. And I still feel even the partial sternotomy, you have to sit in the console with the radiologist to actually figure out, which way you're going to go. Are you going to go lower J sternotomy, or are you going to take it from the superior? So I find that if you sit with the radiologist, you get a fair idea. But even after that, sometimes it is misleading. I agree with you. So when you are partial sternotomy, you do have that advantage of going small skin and a full sternotomy. Regarding the RAT, yes, I think you have to be. We are not as experienced as Dr. Kofidis, but we have to be a little selective in the initial part of our experience. We have to look at suitable aortas and then proceed, and also have the flexibility of 2 spaces. So this is my approach. I think sitting with the radiologist there on the console is key.
Yeah, you're right. And if we have to discuss the availability of technology now, this is, as Dr. Kofidis has said, that each and every patient, if comes for minimal access approach, we must do non-contrast CT. This is a bare minimum. Now we have a 3D printing. We have further the advancement in the CT, where we can exactly pinpoint our approaches and difficulties. Now every technology costs money. 3D printing is still for common use in our country, is far away, but then there is a technology which guides you in a better way. So I just ask Professor Kofidis, what is your take on now utilizing the 3D printing in selected cases of minimal access aortic valve surgery?
You mean 3D printing as in printing of the heart model and the chest, or 3D printing
the printing of the heart, basically to see the the position of your aorta, the calcification, whether you're going to have some issues. You remember that payment was discussing about, the
Right.
last,
Right.
that then
Right.
we both were in the faculty, and he also talked about in the previous mitral, skill development course here.
I never 3D printed a heart, never.
Right.
So, but in certain situations where a patient, for example, has undergone radiation before, or a patient has a concomitant finding of a right, middle, or lower lobe mass, an incidental finding of lung cancer. So then I want to know a bit more. So I may do a 3D reformation of the CT scan. So project it over the ribs as they do in TAVI surgery regularly today. But most of the cases, I don't even ask for these things.
Right.
The simple criteria of the position of the heart, rotation of the length of the aorta relative to the sternum should be in the initial experience the basic criteria for any surgeon to indicate for either mini J or RAT, and that will help you navigate very safely, I would think.
Right. So Lalit, let me ask you. You do have some of the experience in Eastern India. Now, what is the situation of penetration of minimal access aortic valve surgery in Calcutta area, and how you go about working in a major big center in that part of the country?
Yeah, that's nice because in Calcutta we have some surgeons who are into minimally invasive surgery, like Dr. Sushant, who's doing a lot of minimal cases, and I myself do approximately 10% of the aortic valves minimally. For cost reasons, as Dr. Malhotra was talking, maximally we use the mini sternotomy, because the moment you use the cannula and you're trying to do right anterolateral, you need to spend more money. So that becomes very difficult to manage in our situation. Often mini sternotomy, 10% of our cases. The reason we don't do in more cases, obviously, as he said, we have to charge extra. And mini sternotomy, our experience has been very good. We've had no conversions. That's been a good experience for us. And also in the small ladies you mentioned, we are very much more safe and we feel more comfortable because we can convert to a big sternotomy if we ever need. Fortunately, I've never needed it, but we feel safer, inside your heart. The other thing was, in the smaller ladies, we have this access problem for the femoral arteries. And I like doctor's suggestion, Dr. Kofidis' suggestion that we can use both the groins to use two cannulae. I've never done that, but it looks like a good way to handle the smaller femoral arteries. We are having good experience. I've used them with mechanical valves, with biological valves. I have got no experience here with Percival valve. So that part we don't have. But that is our experience in Calcutta, and we are very happy to do this. And if we have cost permitting, we would like to do more cases because our experience has been excellent.
So Dr. Yugal, if I may say something about the sutureless, as we were discussing, the one advantage of sutureless, I find that you can, even in a smaller aortic root, you can put a reasonably good size valve, because you are not put the sutures and the projects. And even if you are able to put a small size valve, which is, gives you equivalent to a regular 19 and 21, which is a good one, I would say. Good,
The gradients
good
are great.
hemodynamics. And similarly, if you are able to put a medium or a large, so that way, we get a very good, fairly good size aortic valve, and that mismatch is, much less. So that is another advantage of the sutureless. So I would say, one should really learn the technique, because sutureless is not that, you can put it in every patient, because it requires a lot of technique. You have to really have a learning curve. You have to understand how you are going to put it, and you have to be precisely doing that, and I would say maybe you have done 10-15 cases through a regular sternotomy of the sutureless, then only you should venture into doing a minimal invasive sutureless, because otherwise you can really always end up in trouble, because if the valve is not seating properly, you can have a paravalvular leak, the valve can pop off, and there can be a lot of problems. So another question I want to ask, I might have missed it because I could join late, Professor Kofidis, about the myocardial preservation. What he thinks is the best way of myocardial preservation, because most of the time we are giving dull needle, but many times we give custodial as well, because again, in India, the cost is an issue. Dull needle, perfusionists can make custodial. We have to really, buy it, or the patient has to spend cost on that. So
Yeah.
what is his take on the myocardial preservation? Because that is one of the very important things, because these hearts are hypertrophied. Septums at times is like 3 to 4 centimeters thick. I mean, it's like a rock. So I would just want to ask his opinion about it.
Thank you very much, Dr. Malhotra. This question is a very important one. So, and as we talk about myocardial preservation, we must refer to 2-3 different things. Number one is know your cannulas, of course, and I refer to the younger people in the audience, not yourself. We must always know our cannulas and the pressures and how we drive the perfusion volume. Number two, there are different schools of cooling down the patient, right? Lamellas, for example, almost doesn't cool, 34 to 36 degrees always. Cheatwood, as you know, invariably goes to 28 degrees, never higher. So and in our case, we individualize the myocardial perfusion by hypothermia, and usually 32 to 34 degrees. That's one thing. As for myocardial preservation, we changed to del nido cardioplegia or modified del nido cardioplegia. It's not subject to the presentation today, but I can share with anybody interested in the audience the exact composition we're using. And the reason why is that, first of all, the main reason I switched to del nido 5 years ago is that I don't see VTs anymore. Right? I don't see VTs. It's so beautiful. So custodial is much more higher volume. You have to buy it. Some countries don't have it. And I learned only when I went around and started proctoring in the region, and I saw that some countries cannot import. So I have to carry the custodial in my luggage. So it's not practical. Go to Del Nido. You won't have VTs. It has ingredients which demonstrate a antiarrhythmic effect. So compared to the custodial, and any perfusionist can mix it for you on the spot. So Del Nido is much more practical. You'll be surprised, Dr. Malhotra, that where did I adopt the Del Nido cardioplegia? I know Pedro Del Nido very well, so it wasn't in Boston. It was in Ibrahim Center when I was proctoring in Dhaka, because a brilliant perfusionist taught me the Del Nido there. You see that we are teaching, but also we are good schoolboys. We are learning all the time through our discussions and panels.
Yeah.
And experience.
So another thing, sir, I want to ask you, Professor Kovidas, suppose if you have to repeat Del Nido, do you modify it, or you just repeat the same dose, or modify the composition, or do something else?
We repeat the same dose, but see, if you do a straightforward aortic valve, I will recommend you tell your perfusionist, give half of the Del Nido. You don't need 2 hours. You need 45 minutes, right? So
yeah.
Sometimes I forget. It doesn't happen often, but sometimes, teaching, concentrate on your residents, you forget to tell the perfusionist, don't give the whole thing. Particularly straightforward mitral valve repair replacement, 40 minutes cross clamp time, minimal invasive, 45. So if you give the full dose, then the heart takes time to recover back to the normal ECG. But custodial is definitely worse. Okay, the heart will fibrillate many times, you shock many times. I've been in difficult territory there with the custodial. But Del Nido
and in a minimal invasive, it is very difficult to defibrillate the heart because the paddles are small. Many times the external paddles would not work. So I agree with you. If you have to repeat the dose, you have to cut down the dose, the amount of the cardioplegia you have to give. So for the younger audience, I would say you always anticipate that how much more time you are going to take. Suppose you have to repeat after 50 minutes or 60 minutes, and you think that another 20 minutes, so just give the half dose, or do not add prokinamide, do not have lidocaine. So then, then you have I would say, your heart comes, spontaneously without giving a shock.
We can share the composition with the society, with the organizers by tomorrow. And one small advice, whether you do aortic valve, mitral valve, if you anticipate problems, let's say you have fibrillations during the procedure, or so the heart is not staying still, or you have difficulty with air and you need some time to recover the air and all these things, don't pull out the vent too early. Leave it in the left ventricle in order for the heart not to dilate. Then you come into a deadly spin from which you cannot recover. We don't want any surgeon come out on ECMO after a straightforward aortic valve.
Professor Kofidis, I'd like to ask you one thing, if can I be permitted to ask?
Yeah,
And
sure.
that is why would you recommend a right anterolateral thoracotomy over a mini sternotomy, except of course the incidence of atrial fibrillation is little less. Otherwise, what are the real advantages?
Okay, in my experience, the patient mobilizes a bit faster, maybe a day faster hospital stay. There is no maximal difference, so people go more minimal and more minimal. Sometimes things are more in our minds as they are real translate in numbers and experience. But in my experience, I've seen indeed that patients will go home maybe a day earlier, instead of 5 days, 4 days. I mean, what's the big deal? Less blood loss, for sure, even less blood loss, less lactate, more albumin in the post-operative labs.
Yeah.
But this is it. Is it the end of the world? I don't think so.
Yeah, because you see, I asked this question because we have to justify the extra cost to the patient and our organization if we want to do this. So that's the reason I asked this question.
So,
Yeah, because
Lalit,
of the cannulation.
let me come on to, now there are a couple of things now. What is Dr. Kofidis' take-home message? Let me enumerate to our younger surgeons. And before going to that, let me also come to this very point that right anterior thoracotomy. See, the sternotomy, whether it's a upper partial, lower partial, is sternotomy. So if we talk of real, the sternotomy avoiding, so the right anterior thoracotomy is, of course, is a better option. As Dr. Kofidis said, the less blood loss. Now, only thing is that when we are doing right anterior thoracotomy approach, we have to do femoral cannulation. If we are doing upper partial sternotomy, we can do, the ascending aortic cannulation, and we can put into the dual stage. And a lot of times we are doing that. Now, so in nutshell, for a beginners, when they want to start a minimally invasive aortic valve, start with a upper partial sternotomy. When you get enough 30-40 case experience, move on to the right anterior thoracotomy. And the classical CT, non-contrast CT, which I also learned actually from Joseph Lamella's couple of points he enumerated, and which I'm going to tell, and a lot of things have already been enumerated. So the approach, number one. Number two, when you are going upper partial sternotomy, please put your chest drainage tube before open the pericardium, because you are going subgified. If you will open the pericardium, you might injure directly the myocardium. So before you open the pericardium, just put your chest tube through subgified area, which I do. Third thing is that Dr. Kofidi said that put your pacing wire before releasing the clasp clamp. And it's preferable to put the pacing wire, not the right ventricular outflow tract, because sometimes this is a thin area and there might be some trauma to that, and it's very difficult to fix that. So go way down as the point where you are usually putting the body of the right ventricle somewhere. Then as Rajni said, it's very difficult to go into for defibrillation. So always keep ready a pediatric, the pad. If you are not able to defibrillate with external defib. Now, if you are giving a external defib, make sure that your lungs are inflated. What happens? Your lungs are not inflated, and you are giving, the external defib. So your current is not conducting up to the heart. So always ask your anesthetist to inflate the lung so that the current from the chest wall goes up to the cardiac cavity. That's very, very important. Now, sometimes you see that your heart is not picking up, go on fibrillating. So maybe because of myocardial preservation is the question, or sometimes air might have embolized to the right coronary. For that, if there is a situation, just reclaim, give cardioplegia, and then come down. Now, as Dr. Kofidi said, if you are using Del Lido, particularly in a scenario where ASD, where it's 25-30 minutes time, I have that experience. We gave Del Lido, waited another 25 minutes to hard to restart, because if you put in a pacemaker, it will not going to generate any contraction, because the whole myocardium is standstill. So again, it's very important that if we are doing a SART procedure, don't give full dose of Del Lido or custodial. If you are using custodial, you need a filter to take out, because 1.5 liter, which is too much. Then one thing I think Dr. Kofidis has not mentioned, maybe because of the fact that what Dr. Lemilas I learned in Miami a long time back, 10, 12 years back, now he stopped resecting the rib, transecting the, earlier he used to do that. And how he used to do, he went through the second space, he opens the pericardium, then put his finger, index fingers, and try to palpate the aortoventricular junction. If the aortoventricular junction is pointing downwards, then he transect the third rib. If it is upward, then he transect the second rib. So that was his, but now I think he has stopped transecting. He has experience, and we also, I in my practice, now I have started transecting the rib. I could able to perform. Just, yes, sometimes I have to clip the memory, vein and artery. And that, as Dr. Kofti says, very easy, nice approach. And we all know that on the medial aspect, the rib space is bigger than the lateral aspects. Now, Dr. Kofti, there is a question for you. And question is from Dr. Prakash Lalchandani. That he says, what is your experience of transaxillary aortic valve, minimal invasive aortic valve surgery?
Zero. So I haven't done any transaxillary aortic valve. I know it's a eventually Japanese-born technique where they also used to do double valves, but I choose to do them separately, and I haven't attempted any transaxillary. I mean, there is no end to surgical ordealism and imagination, and of course you can do whatever you want, but I keep it simple, reproducible, and that's how I teach it through the Mini J and the RAT. Covers 100% of my cases.
So anybody can talk and have some experience. Dr. Cheng, anyway, you are going to present it subsequently. I don't have also. Now I started doing the mitrals on the more lateral. And I have done some ASDs, transareolar approach in a male patients. I have done a couple of young, male where I just make a peri or lateral incision and could able to approach the ASDs. But otherwise for aortic, I don't have. I go either upper partial, same, the indications, or right thoracotomy. Now, with this, let me thanks Dr. Professor Theo Kofidis for such a elegant presentation, and I am sure our junior surgeons and everyone must have gone crazy about learning the more, and they all are waiting your videos. So if you can download in our things, I think we will going to pass on to that, because in our website we will load, and the people are going to get benefit, and of course the the constituent of the dull lead which you have. I request you to please stay till the last, and we're going to have further more discussion after Dr. Cheng's presentation. So thank you. Thanks for your participation. We immensely got benefit out of your presence here.
Thank you.
Let me invite now the second presenters of this program, and let me thank Dr. Cheng joining late night in Australia. Actually, I am sure that we are doing little injustice, but anyway, you don't say that, though I am very dear friendly with Dr. Kofidis, doesn't mean the changing the equation. This is my secretary, which we have done. So anyway, I would have preferred you to first, but anyway, there is Neeta's decision, and I cannot contradict Neeta's decision. And I am sure that Dr. Kofidis must be more friendly with my secretary, Neeta. That's why she has put into a first.
No,
right.
No problem. I also very good friends with Chen Hong. I'm glad to see you again, Chen Hong. Apology.
Right. Perfect.
Hi, Theo.
So, yeah. So the friend, let me invite Dr. Cheng Han Yap. Dr. Cheng is a cardiothoracic surgeon located at the Geelong Hospital and St. John's of God Geelong Hospital, where he is also the clinical lead of cardiac services. He also holds teaching position as a clinical senior lecturer in the School of Medicine, Faculty of Health at the Deakin University, and is an adjunct senior research fellow in the Department of Epidemiology and Preventive Medicine, Faculty of Medicine, Nursing and Health Sciences at the Monash University in Melbourne. Dr. Yap performed a wide range of cardiothoracic procedures, including VATS and robotic lung and mediastinal procedures. aortic surgery, coronary bypass, and cardiac valve procedures. He has an interest in half-pump coronary bypass surgery and minimally invasive aortic and mitral valve surgery. He frequently travels to the Southeast Asia to share his minimally invasive valve surgery techniques. Dr. Yaf has contributed to his knowledge and experience to many publications and presentations. He is currently an investigator of 2 research projects, including the Victorian Lung Cancer Registry at St. John's of God Geelong Hospital and Stable Mates trial at the University of Geelong. With this introduction, let me invite dear friend Dr. Cheng for his presentation, and he is going to talk about the minimal invasive aortic valve surgery, how he does. So we are going to have his personal views and experience on this topic. Thank you. Over to Dr. Cheng, please.
Thanks, Dr. Mishra and Professor Kofidis. I'm glad to be with all of you today. There's going to be a bit of overlap with Professor Kofidis's great presentation, but I'll just give a personal perspective on this field. I'm just going to concentrate on the mini thoracotomy procedures, but suffice to say, I agree with what everyone said, that we probably should start with a mini sternotomy approach before transitioning to a mini thoracotomy approach. These are my disclosures. So just to summarize, we know there are several large series that suggest thoracotomy AVRs are safe and feasible, but these are limited to single center series like Joe Lamellas' series, or select high volume centers like the center in Massa, Italy. The generalizability of these findings remain unclear. There's also many observational studies, comparative cohort studies that suggest the advantages of thoracotomy AVR versus full sternotomy in terms of reduced length of stay, transfusion, AF, infection, etc. But we know these are not randomized studies, so they will be limited by confounding variables and selection bias. At the moment, there are no randomized controlled trials of sternal sparing valve surgery versus sternotomy, although my friend Enoch Akawua in Middlesbrough tells me that despite COVID, they're about 10 patients away from finishing the UK mini mitral study, which should provide a lot of valuable information on whether sternal sparing valve surgery is beneficial versus sternotomy. And I think even though it's a mini mitral study, we can probably extrapolate a lot of the information to aortic valve surgery. We know that less invasive AVR is becoming more popular. This STS paper that is in press in the Annals of Thoracic Surgery suggests that by 2016, about 8% of AVRs are done through a right thoracotomy, at least in the STS data set. But why should one start thoracotomy AVR? This is my personal opinion based on my experience so far. I think it can be learned and performed very well. I think there's a very high degree of patient satisfaction. Certainly, there's a quicker return to full function, even compared to mini sternotomy. Mini sternotomy still violates the sternum, and we know the sternum is a load-bearing area of the body, that all the force from upper limb movements is transmitted into the sternum. But when we do a thoracotomy, particularly when we divide the costal cartilage, that incision is not a load-bearing incision. So I tell my patients beyond the first 3 weeks to return to full function with the use of the upper limbs without any fear of disrupting the incision, and they seem to be able to get back to full activity a lot quicker. I also get the impression the degree of fatigue they suffer is less, so they return to full energy levels within about a month as compared to 6 to 8 weeks with the sternotomy, and I think that's just a function of the amount of tissue injury we inflict on these patients through the surgical incision. Certainly, we do see reduced length of stay and early in-hospital morbidity. And certainly from my perspective, the referring physicians and specialists also believe the recovery is better. They are the ones that usually follow up the patients in the medium to long term, and they believe in it. So that translates to a higher referral rate. And I do believe it's competitive with low risk TAVI, although we can debate that. Like Professor Kofidi says, I think preoperatively it's very important. We scan all our patients with a CT scan. I scan them with a contrast scan that includes the chest, the abdomen, and the femoral vessels, looking for stenosis or calcification to assess the ascending aorta position and the amount of aortic calcification. And with increasing availability of gated CT scans, much like what the TAVI planning CTs obtain, we can start to assess annular size, degree of annular calcification. And more recently, I've also asked my radiologist to report on coronary height because I've had one procedure where, for whatever reason that's not clear to me, I must have injured the ostia of the right coronary artery and had to take the patient back and graft the right coronary artery. So I'm a bit more obsessed about looking at where the right coronary ostium is, particularly in calcified roots, where at surgery it may not be very obvious where the coronary ostia is. Patient selection is important. I think I won't go through this, but obviously it depends on where you are in your learning curve. I would say start carefully, look for right-sided aortas, longer aortas, avoid the vertical and horizontal aortas. But eventually, once you're experienced, as has been alluded to, you can do all AVRs through a thoracotomy, all elective AVRs, I would say. I still avoid redos and I will avoid endocarditis just because it can be somewhat unpredictable and you can find things that might require wider exposure or more flexibility. When it comes to patient selection, when I talk to my trainees, I say there's no real one factor that would rule things out, but you look at the combination of factors. I like to call them difficulty elements. So I've listed some here. I think if there were 2 or 3 of these elements now, I would still avoid doing a thoracotomy AVR. If there were 2 or 3 elements in the same patient, and I would just go for a mini stenotomy AVR as my fallback plan. So very obese patients, we do get quite a few obese elderly patients in Australia, very heavily calcified unicuspid and bicuspid valves with a lot of subannular calcification, just because the decalcification is more difficult through a limited access. Midline or left-sided aorta, as we've discussed, vertical aortas, very deep-chested aortas where the anterior surface of the aorta is more than 12 centimeters from the skin, I would try and avoid. Directly retrosternal aortas, especially with pectus excavatum, chest wall deformities. The very short and very concave aorta I find difficult. Often it's quite crowded and there's not much room to clamp and make a safe aortotomy. I see this group of patients with rigid chest walls and fused medial ends of the ribs in usually barrel-chested males that can be difficult to rib spread and get enough exposure. But I think the one definite condition which we all have to be a bit careful with is that small calcified aortic root in the small elderly lady with fragile tissues. I think certainly when you start out, the tissue handling, your tissue handling skills will be not as good as if you did a stenotomy. So you should try and just be careful about these roots that can tear or dissect if not handled gently. So how do I do it? I just, this is the prep, just usual general anesthesia, central venous line, radial line. I don't use lung isolation, and I'll show you why I think it's not needed. Definitely place external defib pads. I pull the patient right across to my side of the table, and I put a small towel behind the scapula in the midline. I then mark the inguinal ligament and the femoral arteries bilaterally. I also then mark the superior border of the third rib from the sternal edge extending 5 to 8 centimeters, depending on what you, how large an incision you think you have to make. So peripheral cannulation, that's a whole talk in itself. I think certainly I've seen it done very badly, and I think it can be a source for a lot of grief, a lot of morbidity, and even the occasional patient will die from poorly conducted peripheral cannulation. So I have to stress that this is not a part of the procedure that should be taken lightly. It should be treated with a lot of respect. So I use the right common femoral vessels routinely. It's only very occasionally where I will have to shift the cannulation because there's diseased femoral arteries. I make a 2 or 3 centimeter cut, just 1 centimeter below the inguinal ligament. I don't cut in the groin crease. I find that the healing is very poor in the groin crease, and also you're more likely to land up on the superficial femoral artery, where you want to land up on the common femoral artery because it's a bigger artery. I divide layers of soft tissue while I use a Gelpi retractor, and I get my assistant to lift the Gelpi retractor anteriorly as I divide the layer, a thin layer, and then I feel the pulse, and then I reapply the Gelpi. So by doing that sequentially, you can cut down on the vessels accurately without too much unnecessary soft tissue dissection, which will lead to a greater risk of lymph leak, lymphocele formation later, which is very difficult to manage. So I expose the anterior border of both the common femoral artery and vein. I palpate the artery, make sure I don't cannulate where there's atheroma or calcium. I use 5-O-proline purse strings, and then I just move on back to the chest. So I'll go back to the chest now, and then I make my incision over the over the superior border of the third rib. And I split the muscles here, just being careful to seal any muscle perforators, which can bleed later in ICU and be a cause for take back for bleeding. Then once I expose the lateral part of the intercostal space, I basically tell my anesthetist to stop ventilating and open the circuit to air, just disconnect the circuit from the ET tube to deflate the lung. And then I make a hole in the pleura lateral to the mammary pedicle, and then I pack the lung away with a moist pack. So you see here I'm opening, and then I've put a pack in there. And once the pack goes in, then we just restart ventilation, and there's absolutely no need for lung isolation. Then I spend some time dissecting out the right internal mammary artery pedicle, and I divide the artery in 1 or 2 veins separately with wet clips. And then I just find that medial exposure very important to tackle the more difficult midline or left-sided aortas. And then I get a regular sternal, so I put the blade pointing downwards, and I take the guard off the blade, and I basically just cut a V or reverse C shape, cut into the sternum, so I don't cut the costal cartilage. I find when I first started, I used to cut flush in the costal cartilage, and I just find that cartilage can sometimes liquefy and necrose and cause wound problems. So I started cutting into the bony sternum itself, and found that in addition to the better exposure, the wound just heals a little bit better. So here you can see, just using this saw, I just cut a sliver of bone there. And then I put a small Alexis wound retractor and then a mini thoracotomy retractor of some sort. And then when you open the thoracotomy retractor, I think it's important to just make sure you displace the inferior rib to sit anterior to the fourth rib. If you just open it without doing that, sometimes the rib will fracture as the two medial ends of the rib crunch together or hit each other. And then I excise the pericardial fat. Just got to be a little bit careful there. If you try and take too much fat, sometimes the thymic veins can retract out of your field of view and bleed. So just be mindful to seal all the vessels as you go carefully. And then I open the pericardium. Sometimes I'll do this while after I go on bypass, but often you can, as in this case, you can just do it without going on bypass, depending on how tense the right atrium is. Then I place some pericardial stay sutures, again, some often on bypass, but sometimes without. And then I heparinize and go on bypass. But I think it's important to make sure that you don't divide the pericardial reflection superiorly. That's quite a useful point to help retract the whole aorta up into the wound. And like Professor Kofidi says, you really have to spend some time with the pericardial retraction. There's no hard and fast rules, except to say you want to pull it as far anteriorly towards your wound as possible. And sometimes, if you pull certain areas of the pericardium harder than other areas, you can actually make the exposure worse. So don't assume that you just have to pull everything as tight as you can, because sometimes pulling certain parts of the pericardium will tilt the aorta and the aortic valve away from your line of sight. So a bit of experimentation is required, and put lots and lots of sutures. You can even put sutures on top of existing sutures just to get more tension. I find putting an artery clip or Roberts on the pericardium very useful to pull up and get tension on the pericardium while you tie your silk sutures to your retractor or to your wound edge. Otherwise, if you just pull on the silk sutures too hard, they just sort of tear out on the pericardium. So just taking the tension off with a Roberts that your assistant can pull up is very useful. I'll just go along. And then cannulating the femoral vessels. Of course, if you don't have an anesthetist in the room or with toe ability, you need them in the room. So I just Seldinger in a 0.035 180 centimeter wire through an 18 gauge needle. And I for whatever reason, I always do the aorta first, and then I do the vein. And obviously you need to dilate up to just a bit smaller than your cannula size. I routinely use the 17 French arterial cannula. I use the Göttingen one, but I don't think it matters too much. I find that you have to train your perfusionist to tolerate high line pressures so that you can use smaller cannulas. Everyone wants to put in the biggest cannula they can. I want to put in the smallest cannula that my perfusionist will let me in terms of high line pressures, because I think if you put in a smaller cannula than the actual lumen of the vessel, you're not going to get any distal malperfusion problems. So my rules with my perfusionist, which we've agreed on and had protocols written about, is basically I'll put a 17 French cannula unless they're 100 kilos or more, and then I'll put in a 19 French cannula. The venous cannulation, I always use a 25 French Göttingen 55 centimeter cannula. And if the patient's very big, then sometimes I'll put a 29 French cannula in, but it's actually not needed. A 25 French will drain up to 120 kilo patient, no problems. The only one situation where I would use a different cannula is in a very tall patient. So if a patient's over 6 feet tall, the 55 centimeter cannula, sometimes you can't get enough of it in the SVC to get good venous drainage. So I use the Edwards cannula, which is slightly longer. I think it's like another 5 centimeters longer. I would say don't tie your venous cannula in. You will need to readjust it often during the case when you change the position of the aorta or put different tension on the pericardium. So don't stitch your venous cannula in, and be prepared to just move it either further in or further out if your venous drainage changes during the case. The main determinant of poor venous drainage is unfortunately not the perfusionist, it's the venous cannula position. And that particularly happens after aortic clamping. And you got to remember for the younger surgeons, the biggest hole in your venous cannula is the hole on the end of the cannula, not the holes on the side. So if your venous cannula goes up against the side wall of the SVC, you lose venous drainage. So you just have to pull it back. Just sucking more suction on the venous cannula doesn't do anything. If you're not getting venous drainage, good venous drainage at 30 millimeters of mercury suction, you're unlikely to get more venous drainage if you just turn up the suction. You're better off just changing the position of your venous cannula. I have used alternate cannulation sites. I have used axillary cannulation and direct aortic cannulation. If you have very good exposure and a long aorta, you can definitely cannulate at the pericardial reflection and the distal ascending aorta. And I've had problems where I've not been able to pass the wire for whatever reason. I don't have a hybrid lab. I only have toe guidance. So if I can't get the wire into the right atrium, I have no more tricks. So I abandoned femoral venous cannulation, and I have cannulated the SVC with a 3-stage cannula. It works well. And if you've got very good exposure, you can cannulate the right atrium directly. Just a little bit about the conduct of cardiopulmonary bypass for younger surgeons. You have to negotiate with your perfusionist what your expectations are in terms of flows on bypass. I tend to cool just to 34 degrees centigrade, but if venous drainage is poor, I will cool to 32 degrees, and I aim to keep the index around 2. But again, if the venous drainage is poor, I will cool further and drop the cardiac index down to 1.6 to 1.8. I don't think you should have to cool to run lower flows very often beyond that. But obviously you can cool some more and drop your flow some more if you're really having trouble with your venous drainage. I suggest you speak to your perfusionist and come up with some form of protocol. This is our protocol for peripheral bypass. We set down all our expectations so that if I get a different perfusionist on the day, we all know what we're trying to achieve and what we can expect from each other. So I'm very happy to share all these protocols with anyone. Just as an example, it may not work in your system, but at least you know what sort of topics to address. I think we've spoken about a lot of this. So the LV vent just goes in routinely. It can be slightly more difficult to place in a deep, very deep chest because you don't have that angle to play with, but it's definitely doable. So I think this is important. When you try and clamp the aorta through a small thoracotomy, I think the first thing you have to do is you have to turn the flows down and just check around the back of the aorta. In my experience, about 20% of patients will have pericardial adhesions out the back. So you want to divide them either with just a peanut and a Roberts and your sucker bluntly or occasionally sharply with long scissors. And then you, once you know there's no adhesions and there's no problems for clamping, then turn your flows down and place each jaw of the signet clamp or whatever clamp you have on on the far side, usually the posterior side of the aorta. Make sure it's well seated, and then place the jaw anteriorly. And then I sort of look to and fro as I advance my the clamps of my jaw forward, taking care to not injure the pulmonary artery or the left atrial appendage, and get your flows right down so the aorta is almost flaccid while you're manipulating it, and you should be fine. And then make sure you clamp as far superiorly as possible, usually right on the pericardial reflection, particularly with short aorta, so you have more room to work with. You want at least 15 millimeters. I think the Signet clamp's the best, but you can use the Cosgrove clamp if you can't get the Signet clamp, which is horrendously expensive. I think the Cosgrove clamp is a lot cheaper. We've spoken quite a lot already about cardioplegia. My advice to people starting out is to use Del Nido if you can get it. For all the reasons we've covered already, it's cheap, it's lower volume. We can make it in the pharmacy, or the perfusionist can make it, and it works very well with much less fibrillation and better protection. But like most of us, I went from frequent dosing of blood bleach to one-shot plegia with minimally invasive surgery, and I think we've learned a few things there. I think you just have to make sure that the full dose of plegia goes down the coronary arteries. And it sounds very silly to say that, but in the presence of any degree of aortic regurgitation, we're going to lose some plegia. So you have two options. If you're giving the plegia in the root, you can try and account for that by giving a supranormal dose. So for Del Nido, a full dose is 1 liter. You might want to give more than 1 liter. But my approach is that the only way you know you're going to give 1 liter into the myocardium is to give it down the coronary ostia. So if there's a good amount of mild regurg or more, I give a few hundred mils of Del Nido just to stop the heart into the aortic root, and then I open the aorta and give the full dose of 1 liter down the coronary ostia. And I look at the angiogram and work out what the myocardial mass is between the left and right coronary ostia, and then I distribute the 1 liter accordingly down each coronary ostia. I think you cannot overemphasize the importance of getting the plegia right, because when you start out, your clamp times are going to be long. This is my Del Nido cardioplegia hospital protocol. Again, I'm happy to share it. I've just taken little snapshots of the protocol, but it's a 5-page document, and I'm happy to circulate it. And then this part we don't have to talk about much. We all know how to put in a valve, and we know how to do an AVR. So I just cut out the leaflets like normal, bearing in mind that you don't have an assistant sucking the debris, the calcific debris. So you have to be extra careful about how you do it. And then you can stitch in the valve any way you want, interrupted or mattress sutures, everting, non-everting. I don't think any of that matters. The one tip I have is that if you're starting out and you're finding suturing the annulus difficult, just go with interrupted sutures. It's much more forgiving. You can just put them in no particular order, pull the sutures, and keep putting sutures till you've got enough in. And it's usually the right coronary annulus that's difficult to expose when you start. So you might want to put interrupted sutures there. One of the things you have to learn is to use the long shafted instruments. I find that the 30 centimeter long shafted instruments are best for aortic valve surgery, and maybe the 36 one best for mitral surgery. But if your hospital's only going to buy you one set, then just get the 36 centimeter instruments, then you can use them for both valves. You can then tie the sutures in either with the core knot device or with a valve pusher. I must say I use the core knot routinely because I think it's easier than the knot pusher. Even the knot pusher in a small root You still have to get around the stent posts, which are tricky, which can be very tricky to do safely without tearing the aortic root. So once the valve's in, I close the aorta. I usually close the side to me first, the surgeon side first, because as soon as I'm out of that right side of the aorta, I start rewarming. And at that point, the perfusionist will want to turn up your flows. Your venous drainage will suffer a little bit, and your right atrium will fill up and obscure that corner of the aorta. So I tend to stitch up to the midline of the aortotomy from the right side, start rewarming, and then finish the left side of the aortotomy while we're rewarming. And I turn the vent off while I'm doing that second half so that we can start the DA. You can use biological glue, but it's not necessary. And certainly the redos are much better if you don't use any glue. We've talked about putting the RV pacing wise before taking the clamp out. That's very important. I use a Blake drain. Actually, I use two Blake drains, one in the pericardium, one in the pleura. And I tend to put in the pericardial Blake drain in before the clamp comes off, after I put the pacing wires in. And so I use the pericardial Blake drain to exteriorize the pacing wire like this here. You can see on the video, I've basically put the needle of the pacing wire into the body of the Blake drain, and then just pulled it out. And then put it through the skin. The only thing that makes me nervous about this technique is if the patient's completely pacing dependent and you want to pull the drains out on day 1 or day 2. I must say I get a bit nervous, but I haven't lost the pacing wire like this yet. The other thing I do is I also put in the second Blake drain through the same incision, mainly to avoid making a second hole in the chest wall. I think the hardest thing about minimally invasive surgery is dealing with bleeding. All the bleeding usually comes from the chest wall. So the fewer holes you make in the chest wall, the less the risk of bleeding. So I've gone to making just one drain incision for 2 drains. And then I de-air the heart. I take the clamps off and reperfuse very generously. You know, the longer your clamp time, obviously, the longer you have to reperfuse. The cooler you go, the longer you have to reperfuse and rewarm. I would say don't hurry to come with bypass. And then the other thing I do, because we were talking about de-airing, the other thing I do is just before I think the reperfusion time is complete, I fill the heart and I come off. I do this thing where I come off bypass with the intention of going back on. So I come off bypass, usually that last 500 mils of flow ejects quite a lot of air. So I have both my vents in, I come off bypass. If the heart then tanks, either goes into VF because of air, or air goes down the right coronary and the right ventricle starts to fail, I can just run back on without any problems. Otherwise, I come off, eject the last bit of air, and then look at the TOE and make sure my valve's okay. I'm happy that there's no more air around, and then I go back on bypass. Then I go back on bypass and I take the vents out then, and then I come off again, and that seems to sort of avoid that sort of coming off with all your vents out, and then you go into VF and then panic. So I find that very useful, particularly because I don't really de-air properly. I can't shake the heart. I can't do very much. So I don't even use CO2. So I find that sort of two-stage method of coming off bypass very useful. So then with off bypass, we check that the valve's okay. We give protamine, I decannulate, and then just oversew everything. I find that closing the groin, the best way to do it is to put interrupted sutures in the deep layer, not just try and stitch them continuously, because one of the problems with the deep layers is getting all the tissues closed, especially in the corners. So I interrupted 3 or 4 of them onto arteries and then tie that all, and then finish the second and third layer in a thick groin with continuous sutures. I think that's very important to prevent those lymph leaks that we see. I always close the pericardium. I've had the misfortune of having to take 3 of my patients back over the years. And I think closing the pericardium makes a big difference. You don't get that right lung sticking on the aorta and the right atrium, which at a redo, it can be quite difficult to dissect. And then check make sure the chest wall is very dry. Often after you spread it, the lateral corner intercostal muscles would have torn and there's a bleeding there. And also make sure that the wet clips on the memory artery pedicle haven't been knocked off or come loose. And then I just close with Vicryl through the sternum and then through the costal cartilage in a figure of 8. And I close it with the Vicryl suture. I give it a shake. And in the very odd case where it doesn't seem very secure, then I put a plate. But I must say that's sort of less than 5% of the cases now. There definitely is a learning curve. You can see here, this is my first 100 patients. I had one conversion to sternotomy when I put the tip of the the LV vent out the tip of the LA appendage inadvertently. I should have known because when I put it in, there was air in the, when I started turning on the LV vent, there was air, but I chose to ignore it, came off bypass at the end of the case and then had to convert because there was bleeding. And you can see the cross clamp time here is median of 79. But if you look at the sort of last 25 cases, really the clamp times are in the low 70s there. So definitely you can get better. So what are the barriers to adoption? I think it's important to think about these things and acknowledge that there are issues if you're starting out. The first thing to say is working with a limited surgical field is visually and mentally very stressful. If you're used to doing a sternotomy, when you end up with a small incision, for some reason your brain just screams like this is not right. But if you do lots of this, that goes away. The reduced angle of approach from a limited field for your instruments and retraction is a real problem. You are working in a tunnel, and your ability to use sort of annular retraction sutures is very limited. So you just have to acknowledge you're in a tunnel and find other ways of retracting and displacing tissue. The long shafted instruments make a big difference because you can see more around your instruments rather than conventional instruments. And you have to acknowledge that the assistant can't really help you. So you have to use a lot of retraction sutures where you otherwise wouldn't if you had an assistant with a pair of forceps in the chest. I think we have to learn peripheral cannulation with toe guidance and learn it well. We have to learn managing peripheral cardiopulmonary bypass with our perfusionists. I've mentioned working with long shafted instruments. I've mentioned safety of single dose cardioplegia, core knot or not pushing. Learning to expose the valve takes time, and a lot of it's got to do with the pericardial retraction sutures, but a lot of it's also got to do with how you retract the valve with your valve sutures. And then when you start managing the longer cardiac ischemic time, particularly with the poor LVs, the thick LVs, the dilated LVs, how you manage that learning curve without compromising safety, that requires a lot of thought and judgment. But after all that, I do believe it can be adopted by most surgeons. I've had the privilege of traveling to Thailand, to Lampang, to Konkan, and those surgeons are all able to do this operation independently. Abu Yamin in Penang has been able to do it. You can see one of the pleasures I've had operating in Southeast Asia is something I've never been able to do in Australia, which is do an AVR without a metal retractor in the wound, just with a soft tissue retractor. Patients in Southeast Asia generally have a much more shallow, smaller chest cavity. and certainly more flexible rib spaces. So often we don't even have to use thoracotomy retractors. And this is one of my patients that I operated on day 5 post-op. He had a childhood sarcoma and lost a leg. So he was very grateful that we didn't violate his sternum, so he could still use his crutches. But overall, I think it's certainly a good operation. The learning curve is there and needs to be addressed and acknowledged. But I think with a bit of proctoring and mentoring, it certainly can be done by most surgeons. I want to thank everyone for having me on board. And please contact me if you wish. I'm happy to share any of my slides or any of my protocols with anybody. Thanks very much.
Great, great, Dr. Chang. You have taken us from step by step, exposing to the femoral vessel, all the way going to the replacement and eventually closing. I think this must have benefited our junior surgeons who are either just started or ready to start minimal access aortic valve surgery. Great, thank you. Now let's all the panel join and put the doubts to Dr. Cheng and Dr. Kofidis, whatever they have. Before I open to the wider audience and our panelists, let me ask to you, Dr. Cheng. You also agree that, and Dr. Kofidi said that it start with upper partial sternotomy and then move on to the thoracotomy. I believe now that, and everybody, I think all the Dr. Kofidi, you and most of our other colleagues also believe there's thoracotomy is a better approach to go for less trauma, less blood loss. Now, the issue which I want to ask you to address is that out of these two approaches, which is more likely to, sometimes tamponade occurs? Because with, the thoracotomy, you are putting your drain from the thorax side to the pericardium. But additionally, which we don't do. We don't, now I think we got this, the one specialized drain which you are talking, but usually earlier we had a straight drain, which we used to put in the thoracotomy situation from the, chest wall to the piece of the drainage in the pericardium. And sometimes we do have component, collections. And another thing is that sometimes when you pull out the wire and patient is already in a mechanical valve or an EJAN or etc. Sometimes tamponade, which we now avoided, just not pulling out the wire, but just pulling little bit and cut and leave the wire in the pericardium. So just address about these 2 points.
Yeah, yeah, thanks. Bleeding is always a real concern with minimally invasive surgery. I have to say, certainly with thoracotomy AVRs, really, if you think about it, where is the surgical bleeding going to come from? It's going to only come from your aortotomy, your aortic vent site, if you use one. I've gone away from using it routinely and just passively DA, or your LV vent site. There's really nowhere else it's going to bleed from unless you've torn something without knowing. So you can always check all those before all those sites are immediately deep to your wound, so you can see it all before you close. So I think sort of delayed bleeding from surgical sites, they do occur, but should be uncommon. What's most likely to bleed is your chest wall. The 2 or 3 incisions you make in your chest wall, 3 if you use a chipwood clamp, and otherwise 2 sites, they bleed and there's not much you can do about that. What I do is I put 2 blade drains, and it's important that the blade drain you put in the pericardium, you shorten and you put all the grooves inside the pericardial space. You don't leave any of those grooves in the pleural space, because if you do, you will collect chest wall bleeding in your pericardial drain. And you won't know, you'll think it's pericardial bleeding. The other thing I do And so if you use a Jackson Pratt drain, like Professor Kofidis said, make sure all the holes are in the pericardium, and I close the pericardium. So I separate the two cavities. So any bleeding from the pericardial drain then has to be from within the pericardium. What you'll find is that the pericardial drain almost never bleeds. It's always the pleural drain. And the other thing I do is I separate both drains into separate collection chambers. So when ICU calls me at night and says you've got bleeding, I can be absolutely sure that it's pleural bleeding and therefore chest wall bleeding, and I don't worry about it. I've had 3 patients in maybe 150 cases where the pleural drain was bleeding excessively from the chest wall. I've left it. You just leave it for 2 or 3 days, let the hemothorax collect. Usually it stops overnight. Obviously, if it doesn't stop, you're going back to theater. After you've transfused the patient, your second unit, you go back to theater. But most of them will bleed and just tamponade out and stop in the pleural space. And then I take them back and I do a washout VATS.
So, to just add on to what you do to de-air, you just come off and then go back. Now, that is also a point when you are coming off, or one can also check the, the aortic line also. When you are coming off to check the de-airing, that's the point we have seen some of the surgeons, particularly in North America, they just check also because the fragile old age aorta, so that's the chance. So they, one has to make very sure that minimal access aortic line
Absolutely.
is. So when, like the one which you are practicing, I sometimes practice that I come off meantime to de-air completely and also see your suture line. If there is some issue, you can take a additional precipitate. Number 2, all my aortas, if they are not calcified, I always use a 6O proline to suture that. I don't know that there are a lot of questions about that, but my answer is that if you can do a proximal 3-4 proximal vein graft in the aorta with 6O, if you combine that, that is the length of your aortotomy. So I'm very comfortable. Since last 7-8 years, I started using the 6O proline, both end, and always instruct my assistant, please, when you are closing, don't put any cartridge in that area, otherwise that will be blow out. So that's the only, the precautions. Over to Professor Kofidis, please, his comment. Unmute, please.
Yeah, these are very good comments indeed. When I was training in transplant, my teacher was using 5.60 to even do the entire transplant anastomosis. So he hated bleeding, using very, very small needles. And indeed, you see what you're used to and you do well, continue doing it. That's my advice to every surgeon. I would agree with Chen Hong that most of the bleedings are chest wall bleedings. I never worry about tamponade in the minimal invasive cases since I started using the JP drain. I speak for me and my own humble experience, and I can tell any surgeon who wants to start his minimal invasive program, use the JP drain, put it in the back of the heart, all the holes inside the pericardium, as Chen Hon mentioned, and you won't have to worry about tamponade. I didn't have one tamponade with that. I did have re-explorations, yes, but because of, I mean, the valve is repaired, I close the atrium, then I leave it to my resident. And when I was a resident, I had same issue as well. So you will have a couple of re-explorations, okay? We're not perfect. And most of the times these are lack of attention when you are closing up from the big incision side or from the Chitwood clamp or whatever else clamp you use. Yeah. So small fat tissue bleeders, it can be anything. Yeah.
Yeah, so another good point for minimal access aortic valve, I think Coronat is a very good tool, and in India it's expensive everywhere, but with our the Rajneesh and myself, we both started using in India, and now it's available, freely available. Of course, that's cost close to ₹1 lakh. It's 100,000 rupees, for 12 to 14 knots to apply that. So it's expensive. But nonetheless, if patient can afford, the regalia are abulous, they can easily afford this one. And this is particularly, Dr. Cheng was mentioning, the Dr. Kofri is also, when you have a small annulus fragile aorta, if you tie the knot with your finger, you can tear. And this, I had the same incidents 3 days back, where the surgeon site area was tearing, and then we have to take interrupted pleated suture 3-4 and then continued. So that's the issue which can easily be solved with core knot, or even with the knot pusher. You are much better than tying directly. Even in open cases, sometimes if I have that kind of issue, small aorta or fragile, I use knot pusher than putting the finger inside. Now, another question which I want to ask, and if Dr. Kofidis remember that Dr. Lemilus uses Miami retractor, in the aortic and also in the mitral. So, do you people use, because in the minimal access, the right thoracotomy aortic valve, retracting the lower segment of the arteriotomy, aortotomy segment, sometimes, it's very difficult for assistant, because he's not able to watch, and if they retract without seeing properly, they tear the both end of aortotomy, and aortotomy becomes rigid and elongated. So how you address both of you for looking to the annulus and taking the suture? And sometimes we do have a problem of locating the right coronary ostia to giving a cardioplegia if there is a some regurgitation, if you're not giving only root cardioplegia.
A few tips on that. In the open median stenotomy cases, when we open the aorta, what we do is usually 3 times 4 prolonged stitches all over the place, 2, 5, 11, whatever, and we retract to have a better view. We put the stitches usually on the aorta itself. Now, in minimal invasive surgery, I suggest every surgeon, if you are to put exposure stitches, put them in the commissures, deep inside. So the first 3 stitches go into the commissure. Even if you do a aortic valve replacement and you use your usual pleated stitches, I start with the commissures. It gives me the ultimate exposure. And then 3, 3, 3 in between, something like that. Now, I don't use the lamellas, plastic device, whatever it is. When you do the endoscopic procedure, sometimes it helps. Let's say if you need to go and address the mitral valve from the same position. There are rare occasions whereby you go to the papillary muscles, the mitral valve, but I don't regularly use it in open non-camera assisted RAT procedures. But I do the commissural stitches first, and I use them as exposure at the same time.
Yeah, I've tried to get those lamellas contractions, but I can't get them. If anyone can send me the aortic valve one, I would be very grateful. I've tried to get them, but I agree with what Professor Kofidis says. You have to put careful retraction sutures as you see fit. So for the difficult aortic valve, what I do is when I start, I make my aortotomy, and then I put 2 or 3 4-Proline sutures through the adventitia on the lower side of the aortotomy, as Dr. Yugal says, that's the bit that sort of falls forward and falls into your line of sight. So put a series of interrupted folds, catch the adventitia, and then instead of pulling it out of your incision, you're working in a tunnel, so you don't get any lateral retraction. Put one end of that suture through the pericardium in the direction that you want that particular suture to pull. You don't have to put both ends through the pericardium. You just have to put one end through the pericardium and then pull both ends out of your wound, put in an artery, clip it to the drape, whatever. Put 2 or 3 of them, and that will support that anterior lower part of the aortic root from falling into your line of sight. Then if the valve is very far away, I do exactly what Professor Kofidis says, either 4 prolines through the commissures, pull them right out. You can get the valve really high just by doing that, or I just put my valve sutures through that, save 3 more sutures, put your valve sutures through the commissures and pull it up. And sometimes you have to do all these before you can even give the osteopleach, because sometimes you can't see the coronary ostea in a very difficult exposure. I must say, the one situation I find very difficult is the very calcified aortic root where you can't find the right coronary ostea, or it's a non-dominant right coronary. So the coronary ostea is very small and elusive, and your coronary osteal cannula cannot engage it and get a seal. And you've got some AR. So when you gave the pleats down the root into the root, you probably didn't give much down the right coronary. And then you have trouble. I've had a few of these cases and I worry about the right ventricular protection a lot. I'd be interested to see what else you do. I just cool a bit extra and go a bit faster and hope the right ventricle survives. But the non-dominant right, the very calcified anterior aortic root where you can't find the right coronary ostea, they're all a little bit scary doing those cases.
Now the Medtronic has got a cardioplegia cannula, which is a soft, doesn't go inside the ostea, but it goes into the wall of the aorta to oppose that. It's very soft cannula. I've seen that somewhere. So just you push that, and you are against the the imaginary ostea, and they give the cardioplegia. So that saves both ways. Neither no injury if there is a calcification in the ostea of the right coronary or even in left coronary. You just push that soft tip, this flat one. Now, another thing just I want to advise Dr. Cheng is that need not to go to Miami to Dr. Lemula's for that retractor. Your own friend in Australia, Robert, what is his name? Another, the aortic surgeon, Robert, he has developed that, there is one retractor, which is his own invention. I just forget his name. One of your colleague who is also doing a lot of minimal access aortic surgery, Robert or something. Someone.
Is it Trevor Fayers in Queensland?
Oh yeah, I think
Trevor.
No, it's not Trevor. It's not Trevor. No. Yeah, there's another one. Anyway, I just forget the name. I'll let you know. Okay, so let's move on to invite our the panelists to their viewpoints and what they feel and what they want to ask few questions to.
So, Dr. Yugal, I would like to make a couple of comments.
Yes.
So these comments, one thing is like, I agree that if you have cord knot, it really saves you time. And another thing, I mean, at times in minimal invasive, I mean, seating the valve, a regular seating of the valve can be a challenge because your valve, I mean, keeps on slipping from one place or another. So what I use is like I use 3 tourniquets. The regular tourniquets, so your valve is seating properly, so you don't bother about it. And then you keep tying your sutures, whatever you want to. Either you are using a cord knot or you are using your knot pusher or by your hand. So it always helps. You take 3 pediatric tourniquets, put it at the 3 commissures, so your valve is seating, and then you just keep tying that. That really saves you, I would say, the botheration that your valve is going to slip out of this or it's not seating properly. About the cardioplegia you said, I would say, as we are doing Dalnido or something, and in most of the patients, when you are using it for the aortic stenosis, I think 1 dose of good cardioplegia, you can really complete the procedure. And antegrade cardioplegia, is always better for protecting the right myocardium than the retrograde. And we had been using retrograde. I use in a couple of my patients retrograde, antegrade both, and that really saves you, I would say, time if you are have to give you a cardioplegia. Plus, I also believe that when you are giving retrograde cardioplegia, or you can give a hot shot and then your coronaries and all DA, and then it really saves you. And when you are giving hot shot and blood, so most of the time your heart will spontaneously come and then it is good. And another thing Professor Koffidas said about the venting. So one has to be, I always use LV vent, through the pulmonary vein, superior pulmonary vein, and a hypertrophied heart, it really helps, because otherwise if you are not putting the vent, your heart starts fibrillating, and that can be a big problem. So I would say, I mean, do as you do in a regular one, but you always put a vent and take out the vent when your, I mean, your heart has really rewarmed, and then your heart has started ejecting. Then you take out the vent. Don't be in a hurry to take it out, so that, I mean, your heart starts fibrillating, and then defibrillating is a problem. I think these are certain comments which I wanted to make. I think, and if anything else, I mean, we can add.
Thanks, Rajneesh. And I think with my office bearer of the society, on behalf of society and all the audience which have witnessed today's great academic feast, let me thank both Professor Theo Kofidis and Dr. Cheng for coming on the board and addressing and giving their viewpoint how to evolve and develop minimal invasive aortic valve surgery. Thanks. In this time you are awake and still talking to us. That's great. To our fellow friends, that the next the module will be on 13th of March, and we are going to address with two world authorities on minimal invasive coronary artery surgery. On behalf of society, I'm really thankful to both of you, and wish that in some other future endeavors you are going to participate, maybe in person, maybe next year, and not in this year, maybe when we are going to have a combined meeting with SMICS-SI and SMICS workshop, and that is scheduled in October, and I will send official invitation if the international travel may be permitted and things are settling down in the COVID front. So with bottom of our heart, with my colleagues from SMICS-SI and all the participants, thanks to both of you gentlemen, and of course my fellow panelists and everybody who witnessed today's event. Thank you. Do join us again on 13th of March, same time, for minimally invasive coronary artery surgery. Thank you. Thanks and
Thank
good.
you.
Thank you.
Thank you. Thanks.
Thanks.